Welcome to this segment of our series of Sound Mind. This is a series on cognitive aging that is put on by the Stanford Alzheimer's Disease Research Center. Tonight, this particular segment will take a closer look at Parkinson's disease, what it is, how it is diagnosed, and what the treatment options are that are available. I am your host for the series, Dolores Gallagher-Thompson. I'm a psychologist and a research professor in the Department of Psychiatry at Stanford University School of Medicine. Tonight we are joined by Dr. Kathleen Poston and Mr. Stephen Russell, and we're very happy to have the two of you here because we know of your expertise in this field, and we know our viewers will be very glad to hear what you have to say. So I'll start with Dr. Poston, introducing her first. She is Assistant Professor of Neurology and Neurosciences at Stanford School of Medicine. She is also a practicing physician who specializes in movement disorders at Stanford Healthcare. Her research lab seeks to understand the underlying brain circuits associated with movement disorders such as Parkinson's disease, and in particular the changes in this brain circuitry that leads to specific symptoms, the motor symptoms, cognitive symptoms, and behavioral symptoms. Stephen Russell is here representing the Stanford Parkinson's Community Outreach Program and Information and Referral Center. That center is a partnership between the American Parkinson's Disease Association and Stanford University. So thank you again for making the time to be on our show.
My pleasure.
Thank you.
And I think we'll start with Dr. Poston. Could you tell us, please, what is Parkinson's disease?
So Parkinson's disease is a neurodegenerative disease. What that means is that brain cells that are critical for everything that the brain is supposed to do are slowly affected by this disorder and unfortunately die and become diseased over time. And then those changes lead to the symptoms that a patient experiences as Parkinson's disease.
Can you tell us what some of these symptoms are?
So the symptoms that we think about for Parkinson's disease really can be divided into two big categories: the motor symptoms and the non-motor symptoms. So the motor symptoms, which is really what most people think of as Parkinson's disease, are things like slow movement, stiffness in the muscles, shaking of the limbs, which we call tremor, as well as gait and balance problems. But just as importantly are the non-motor symptoms, things like constipation, urinary frequency, depression and anxiety, as well as things like memory problems and even dementia.
So there's a wide variety of symptoms that characterize this particular disease.
Absolutely, absolutely. And what's remarkable is that any two patients can have a completely different collection of these different symptoms. All patients have some of the motor symptoms, but not all of them. One patient might have tremor, another patient doesn't ever have any tremor. Similar with the non-motor symptoms. Some patients will have some of the non-motor symptoms, others won't have those motor symptoms. So every patient's a little bit different in which symptoms they personally experience.
Now, how do you arrive at a diagnosis of Parkinson's disease?
So this is really based on the clinical exam. We look for cardinal symptoms of slowness, stiffness, and tremor that are very characteristic on the exam. And there are certain criteria that have been developed over time that we as clinicians use. Sometimes we'll also do a scan of the brain to make sure there isn't something else that's causing those symptoms, like a stroke or a brain mass. And sometimes we'll do some blood work, again, to make sure there isn't something else that's causing things like being hyperthyroid, and that's what's causing the tremor. So we'll look for other causes that could be mimicking Parkinson's disease.
Yeah, and I imagine if you found one of these other causes, then you would treat that.
Absolutely.
And perhaps some of the symptoms would not be present anymore.
Exactly.
Yeah. Now, I understand that over time, Parkinson's disease progresses. So can you help us understand what is that progression like? Is there a typical progression, and how long does it usually take?
So similar to the variety of symptoms patients experience, there's a big difference in how each individual patient experiences the progression. And progression really happens in two forms. The first form is that a certain symptom somebody might have might get worse over time. Let's use the example of tremor. Someone might have a very small tremor when they're initially diagnosed, and 5 years into the disorder, that tremor might be much more severe. The other thing that can happen is that they can develop new symptoms that they didn't have initially. So for instance, someone when they were first diagnosed might not have had any gait or balance problems, or they might not have had any memory problems, but 10 or 15 years into the disorder, they might be having severe problems with walking and balance and have a lot of falls, or they might have memory problems or even dementia at that point. So new symptoms can develop along the progression of the disease.
So it sounds like the progression is also very individual.
Very individual, yes.
And there isn't a common trajectory that most patients would experience.
Not necessarily. Just because one patient develops certain symptoms over a period of time doesn't mean that another patient will experience those same symptoms. There's a very large variety amongst patients.
Now, is it true that some patients develop dementia?
Yes, it is, unfortunately. And in fact, memory problems and dementia are probably one of the symptoms that really has the biggest impact on quality of life, on patients' experience of the disorder, as well as the impact on family members and caregivers. So it's a really important symptom to be aware of.
And does everyone with Parkinson's disease develop dementia?
Thankfully, no. Certain patients
That's
are at
a
higher.
relief.
Yes, it is, isn't it?
Yes.
Some good news, right? So not every patient will develop dementia, and in fact, when somebody might develop memory problems also varies. There are some patients who unfortunately do start to develop the memory problems of Parkinson's disease very early in the disorder, within a year or two of the diagnosis. But then there are other patients that might not experience any memory problems, again, for 5, 10, 15, even 20 years out. So it really varies when somebody might start to experience memory problems.
So I'm thinking then perhaps there might be some risk factors that tend to hasten the progression or that might be more likely to result in dementia. Is that the case? And if so, can you tell us what some of those risk factors might be?
Well, to answer broadly, we don't 100% know why one person gets memory problems and another person maybe doesn't get them for many years. So we don't exactly understand this discrepancy. But there are some things, as you said, that increase one's risk. So probably the biggest one, unfortunately, is age, which is something none of us can get away from. So patients who are diagnosed with Parkinson's disease at a younger age, in their 40s, 50s, or even 60s, typically don't develop memory problems at the very beginning of their disorder. They can, but it's not as common. Unfortunately, folks who are older, in their 70s or 80s when they develop Parkinson's disease, are at higher risk for developing memory problems and dementia. And that doesn't mean that every 70-year-old who gets Parkinson's disease will definitely get dementia. It just means they're at higher risk.
Okay. And can you tell us what are some medical treatments that are available? So people have this variety of symptoms. We don't know exactly how the progression is going to occur. So how do you provide medical treatment to these people?
So it's very individualized, and we really target the therapies to the specific symptoms that any particular patient is experiencing. So if somebody's having a lot of tremor or a lot of gait and balance problems, we might give them a different treatment for other symptoms. The majority of the motor treatments are really targeted to replacing dopamine. So in the very beginning, I said that it's a neurodegenerative disease where brain cells are affected and die over time. Those brain cells, a lot of them produce dopamine, a neurochemical that we all need for normal brain function. So a lot of our therapies are in replacing that dopamine. And there's a pill that you can take that actually breaks down in the brain and becomes dopamine. And so we replace that dopamine, and it helps a lot of the motor symptoms in particular. The non-motor symptoms, it can be a little more difficult to treat. And again, it's tailored treatment that are specific to the constipation or the depression or the memory problems.
Well, thank you. That's an incredibly helpful overview of the disease and medical treatments available. I'd like to now turn to Stephen and ask if you can help us understand non-medical treatments that are available, interventions and services in the community for Parkinson's patients.
Right. So the community outreach program at Stanford works with anyone. Actually, our area is from Northern California, from the border of Oregon, all the way down to Bakersfield. And so we cover a very wide area. And it's an information and referral center. So we provide information, which we'll get to in just a second, as well as referrals. So for anyone, we always refer first off to someone who's a movement disorder specialist. That's definitely the platinum level of care that you want to get as a Parkinson's patient. But in many areas, they're not available. So we also know all of the neurologists, and we also work on referrals for physical therapy and occupational therapy, as well as speech therapy, because quiet or garbled speech is often a problem with Parkinson's as it develops.
So there's a broad array of non-medical services.
Right.
Yeah. Now you mentioned exercise.
Yeah, so exercise is
What
always...
kind of exercise?
Well, all kinds of exercise, pretty much anything that people are willing to continue to do is good. But particularly anything that stretches, that works on balance. So on our website, parkinsons.stanford.edu, we have listing for exercise classes and Parkinson-specific exercise classes, such as dance. We also have rock steady boxing, which is a boxing program, non-contact boxing. Head trauma is not a good thing for Parkinson's.
Yes.
And then there are yoga classes, there are qigong classes, all kinds of programs. And again, they're all over the Bay Area and Northern California, and always encourage people to participate as much as they can. And one of the things that I do is also run support groups for both patients and caregivers.
I'm sure that's very important.
Well, it's really important because so much of what happens with people with Parkinson's inside the clinic is all about medications or surgery, and very seldom about anything else, which can be 80 to 90% of the other symptoms you're dealing with.
Yes.
So you have all kinds of things that happen. You're stiff, your balance is off. You just have many, many things that happen.
Yes.
And so anything that can encourage people to move safely is really important. So, and then we also talk to the caregivers and say, don't forget about you. You know, you are a very important part of the care team that everyone needs.
So it sounds like that what you offer are complementary to one another.
Right.
Yeah, that it sounds like one without the other would not be sufficient or adequate.
Yeah, if I could take
most
just a
patients.
second. When my dad was first
Sure.
diagnosed, he was given a diagnosis of Parkinson's, no other information, and a prescription for Sinemet, for the major medication. And that was it. And then he went home. And he said, okay, what does that mean? And so now, that was 25 years ago. Now it's so different. And it's, you know, Parkinson's is a very challenging diagnosis, but there's so many things you can do to make your life better as a patient and also as a caregiver. There's so much more information out there. There's so much more resources out there and so much more support. And that is actually, we work very closely with the clinic.
Well, I think both of you mentioned a care team.
Yeah.
And that's not a term that many of our viewers might be familiar with. So can you tell us, what do you mean by a care team?
Well, on my side,
Who's in it?
Yeah.
it's because it's a chronic disease and it's a very long-lasting disease in most cases. You have to do all kinds of long-term planning. So not only financial planning, which is very important, but you also have all of the things you need to worry about. If you're working, how long can you continue to work? If you have to quit your job, what does that mean for your income? Can you keep your house? Can you stay in the area? Do you have kids? I mean, there's just so many things, and you can't do it on your own. Particularly as the disease progresses, you need support. So I encourage everyone I meet that's newly diagnosed to sit down, talk to their family members, their friends, if they're in a faith community, to their faith leaders, anyone that they're working with, and have them focus on how they can start building their team now. Oftentimes Parkinson's, my dad had a very mild case of Parkinson's, all through the whole course of his disease, but many people, it progresses slowly, and then you'll hit, suddenly something bad will happen, and it's an emergency. So it's much better to stay focused early, if you can. And then the whole focus should be on the quality of life for the person at all times.
And on the medical side, who would be on the medical care
I
team?
absolutely agree with the idea of a care team, and I really rely heavily on that care team. Things like I had mentioned, these non-motor symptoms. So sleep disorders is a really common problem. Patients have trouble falling asleep at night or staying asleep. They might have obstructive sleep apnea or something that can be treated, and so I will refer them to the sleep center to be evaluated. I mentioned constipation and urinary frequency. I frequently refer patients to a urologist or a GI doctor, and then those symptoms like depression and anxiety, very commonly I'll get the input from a psychiatrist or a psychologist or some other therapist to try to treat those symptoms as well. So really having a medical care team along with the ancillary members like the physical therapist, speech therapist, and occupational therapist, and then the personal care team. This is all critical to really effective treatment of Parkinson's disease.
Yes, and it sounds like for some people at least, they could be living with Parkinson's disease for quite a long time.
Yes, absolutely.
As you mentioned that some people are diagnosed relatively young, and others maybe in their, maybe not till their 70s or something. So I guess you could be living with it maybe 20, 30 years.
Absolutely. The average age of onset is 60, but that's very deceiving because there are absolutely patients in their even their 30s, but 40s and 50s who develop Parkinson's disease, and they easily could be experiencing symptoms for 20 to 30 years and actually doing pretty well with their symptoms for over that duration of time, relatively speaking. So it's something we really think of this as a chronic condition.
But it sounds like you're all working to engender hope in people, you know, through the medical side, breakthroughs that are happening, research that's going on, and then the non-medical, these new programs that you develop. And I think you probably will keep developing them as something else comes along that might be novel and seem appropriate. You'll probably add that to the repertoire. So I realize we haven't given Dr. Poston a chance to talk about her research. And would you like to take this opportunity to tell us a little bit about your research and how you see that impacting the field in the future?
Absolutely. And I agree that research in Parkinson's disease is absolutely critical. A lot of these things that we've talked about here tonight, we have some treatments for, but they're not good enough. We can't reverse Parkinson's disease, and we can't ultimately cure it, which is what we need to do. We also have a lot of unknowns. You can imagine how frustrating it is for a patient to come into the clinic and be diagnosed and not know whether they'll develop those memory problems in a year or in 20 years. Talk about a completely different experience of Parkinson's disease in those two scenarios. So a big part of my research is trying to understand this variety of experiences of Parkinson's disease. What is it that leads one person to have certain symptoms like dementia very early and another patient really not experience it at all? And it's important for two reasons. One of them is just prognosis, helping patients understand what is in their future so that they can plan more appropriately and come up with a better care team. But the other part is maybe we can learn something from those folks who don't get memory problems for 20 years. Maybe there's something special about their genetics or things that they've been doing in their life or exposures or exercise that's protecting them in some way that we can then harness and actually use for the people who are at higher risk. So that's really the focus of my research, is understanding this discrepancy so that we can better give patients prognosis as well as maybe harness some of those things that are working well for some patients and use it to benefit others.
Yes. Yeah, so are there other studies ongoing at Stanford that also involve Parkinson's patients?
Absolutely. We have a fantastic balance and motor lab in our clinic, and there are several studies that are going on that focus on helping to prevent falls and understand why, again, some patients have more balance and motor problems. So that's another big area. And in partnership with the Alzheimer's Disease Research Center, I know it's called the Alzheimer's Disease Research Center, but a very large part of that is actually Parkinson's disease. And we are actively recruiting patients with Parkinson's disease, those who don't have any memory problems, as well as those who do have memory problems, so that we can understand these differences between those two parts of the disorder, and to understand that entire piece of why does memory problems happen in some people, to understand that better.
Well, I have a question that we haven't touched on yet, and that is trying to understand the genetic aspects. You know, is there a strong genetic load for Parkinson's disease, or or not? Or would you say it's
such a great
unknown,
question.
or it's still unknown?
Such a great question, and there's so much research going on in genetics right now. So there are two genes that seem to be risk factor genes, pretty strong risk factor genes for someone developing Parkinson's disease. And we're doing a lot of research at Stanford on those genes. And it turns out one of them might also increase your risk for the memory problems as well as just the Parkinson's disease. And so understanding what these risk factor genes mean, do they really increase the risk of dementia or not? This is critical for us trying to understand this personalized approach to treating Parkinson's disease. And that's all part of this Alzheimer's Disease Research Center, is there's a large focus on genetics as part of that study.
Great. That's really good to hear, because that seems to me to be very promising for the future.
Absolutely.
You know. And Stephen, back to you again for a moment. So are there studies that you're involved in, or community-based studies, or studies that are looking at how these different programs that you have might slow the progression? Is there any, kind of cross-cutting research?
I'm working with the ADRC, of course, in recruiting Parkinson's patients as well as patients with Lewy body dementia. Other than that, we spend our time on the web and talking to everybody we know about what's there, because the patients are asking us constantly. And the caregivers are also asking, what can we do? What is out there? What hope do we have? And the patients that do well always have a positive outlook. No matter, I've met people who were really in very bad physical shape, but emotionally very, very strong. And those people always have the best outcomes. So, anything we can do to help them build that resiliency is really, really important.
So just like dementia is not foregone conclusion with Parkinson's, neither is depression. It sounds like there are people who somehow have the strength that they can roll with these punches.
Well, and you talk so much about Parkinson's, about loss, things that you lose. And oftentimes I had a caregiver that came to my group the first time, and she said, my husband's not working, he's not going to be available to me anymore. And she just was going on and on and on. And then she mentioned that he was a professional tennis player and he could no longer play tennis. And one of the other caregivers said, how do you think that makes him feel? And he was okay. He was okay. It's like, I can't play tennis now. I can't play as well as I used to, but I'm still going to go out and do the best I can and enjoy it for what I enjoy it for. And that's really an important part of how successful people are.
Yeah, and I would think that people who are in this area and able to take advantage of all these programs that you're talking about, the clinical care, community-based care, the research programs, that they might have an advantage, you might say, over people who are not in such an enriched environment, because they're exposed to all these things that are likely to be helpful. I imagine it would be more difficult if you were in a different part of the country or a different part of California where the resources weren't as rich as they are here.
It is true that we are very fortunate here, but what's fantastic is that there are so many resources on the web now that really can help people, even if they don't have the physical locality of being able to be part of these programs, of being able to learn about them and hopefully make them part of their own individual communities, because I think that it is really important to have these exercise programs and these different ways of engaging in every community. And I think that's been a focus of a lot of the outreach that's been in Parkinson's over the last 10 years is let's get these types of resources into more communities.
Yeah, we spend a lot of our time talking to people in the Central Valley, extreme Northern California, down on the coast, Central Coast. It's like we want to do all these things, help us get them going. And
Yeah, so you're-
there are resources out there to get them help. So that's really.
I know that some of the local YMCA's have special programs for
Yes.
Parkinson's persons and memberships and so forth. So, well, are there any closing comments that either of you would like to make, as our time is drawing to an end?
Well, I think I'd really just like to end on a positive note. As I mentioned, there are a lot of symptoms and a lot of experiences of Parkinson's disease that can be very hard for patients and their families. And we don't have a cure yet, but that doesn't mean we don't have hope. And there are so many things that we can do to improve quality of life today for patients and to make their experience of their Parkinson's disease better. And I think those are things to focus on. And both things like exercise and outreach are important. Being involved in research, knowing that you are part of that solution. How exciting is that, to be part of the solution that might help yourself, might help your neighbor, might help your children. That's a really hopeful thing, I think, and I think an important thing.
And I'm sure you would agree.
I would, and I really think that, as I said, the attitude for both the patient and the family is really critical because it is such a long-term disease. You have to really be in it for the long haul and continue to enjoy every day.
Okay. Well, thank you. I think that's a wonderful, wonderful way to end our segment. So we truly appreciate the time that you have spent with us and the expertise that you have shared. Because I think it's been very helpful to many people in the community and many individuals who may not even know much about Parkinson's disease. I think we've learned a lot from hearing what you've had to say tonight. So, and I would like to close our segment by asking our viewing community to consider volunteering for the studies at the Alzheimer's Disease Research Center. We have many ongoing studies, as Dr. Poston mentioned, for persons with Parkinson's disease, with cognitive changes or without cognitive changes. And we're always looking for healthy older individuals to serve as controls in our studies. The phone number on your screen is the number that you can call for more information or to volunteer. Thank you very much.